Good morning, everybody. On behalf of the ENT department of the University of Frankfurt, I would like to welcome you to this second meeting on statements on head and neck cancer. The chairman of the meeting, Professor Knecht, will address his welcome in a few minutes. However, I take the privilege to give you some introduction into head and neck cancer. Before I start, I would remind you that today is the birthday of Wolfgang Amadeus Mozart, who was born in Salzburg in Austria, the country where I grew up. And you know, the music of Mozart brought together so many people in his enthusiasm, and we would like to bring together people on the topic of head and neck cancer, people working and having efforts in treatment in this modality. Head and neck cancer, next slide please, accounts for 6% of all cancers worldwide, and there are reports of more than 600,000 cases per year and 300,000 deaths worldwide due to head and neck cancer. Of course, more than 90% are squamous cell carcinoma, and they are largely due to tobacco and alcohol abuse. More than 2/3 of patients present in stage disease in stages 3 and 4, and unfortunately survival rates are not improving. Also, efforts have been done in research and treatment combinations. Next slide, please. So how do we treat head and neck cancers? In early stage disease, we can do surgery. This can be done as endoscopic surgery, like shown here in a vocal carcinoma, or it can be done in open surgery, for example, of a hypopharynx carcinoma, which has to be treated with a forearm flap, even in early stage in some cases. And of course, there is radiotherapy as a treatment option in early stage disease, more common in US like in Europe as an outcome of our last meeting. The 5-year survival is reported to be 91% in stage 1 and 77% in stage 2 disease. What are we doing in advanced disease? The standard therapy over decades was radical surgery whenever this was possible, combined with postoperative radiotherapy. 5-year survival has been reported to be between 35% and 65%, depending on the type of carcinoma. However, addition of chemotherapy to radiotherapy showed improvement, like demonstrated by Cooper and Forestier, an improvement in local control, disease-free survival, but unfortunately no improvement in overall survival. Next slide, please. By adding chemotherapy, organ preservation came into the focus, and there are 2 studies. All of you know them, the Veterans Affairs studies and the EURTC study. In a similar setting in both studies, chemotherapy and radiotherapy was compared versus laryngectomy and radiotherapy, and it could be demonstrated that laryngeal preservation was possible in slightly more than 60% of cases with a similar overall survival. Chemotherapy may be intensified by adding, for example, docetaxel to cisplatin and 5-fluorouracil, and this has been demonstrated by Posner in improvement in rates of complete remission, and there is maybe a slight improvement in overall survival. However, intensified chemotherapy has to be discussed in terms of toxicity, side effects of therapy, and quality of life. So what can we state today? Treatment of head and neck cancer is a multimodal, interdisciplinary form of therapy. And what are the challenges for the future? Of course, these are molecular targeted therapies. More than 90% of head and neck cancer express epidermal growth factor receptor, and there is a monoclonal antibody targeting EGFR, cetuximab, and this should be included into the treatment. It's already included even in our series in Frankfurt. However, there should be a first-line setting that we get more experience with this molecular targeted form of therapy. And from oncologists, we can learn there are different targets like inhibition of signal transduction, like inactivation of oncogenes, activation of tumor suppressor genes, and induction of apoptosis, and so on. All this should be a topic of such a meeting and discussion. Thank you very much for your attention, and I would like to ask Professor Knecht to come and give his welcome.